Well, greetings, 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 greetings in the wonderful and precious name of Jesus. Our Son coming, Lord and Savior, comes what may. We got to give him the praise. Oh, praise God. And I can see that there are many of you already on. I can see I got your text messages. You were there waiting. And we know that persons are going to be coming on. We just want to encourage you to get in the chat. You know what it's all about. Get in the chat. Tell me where you're coming in from, where you're viewing from. And, don't forget, you can go ahead and share with your friends, your groups. And, just enjoy what is coming to all of us. And so I just want to say, man, I'm so excited to see what's happening and what's going to happen on this program with Dr. Leroy Campbell. All right, all right, all right, all right. Yes. All right. We see Venetia coming all the way from Grand Cayman. Yes, the Cayman Islands is in the house. And we really want to give God thanks for you and just get all the rest of the friends on, brothers and sisters, and, just get everybody on. And I just want to say, hey, Dr. Leroy, how are you?
Hey, Doc, I'm good. I'm good. I'm feeling great.
Yes.
Looking forward to our chat tonight. We're going to be doing some good things and helping some people. So I'm very excited.
Yes, and guess what? Um, you know, this was requested. This was requested. I see Jamaica's in the house. Wonderful, wonderful. Glory be to God. Yes, once you get in the chat, we'll be able to feature you and, show you how important you are to us. And because once we get started in a few minutes, we will just have to stay focused. And so, it's good to have you. It's good to have you, Dr. Leroy. I know you're very busy, and I know it must have pulled a lot out of you, a lot of sacrifice for you to come on like this. And we know there's a lot of folks that are viewing also on Facebook, on YouTube, and they'll be coming in. And before we get started, I just want you to flow with it because I would have had some knowledge. Wow. But I show off on me big one of them cup.
Hey,
Oh,
I'll give you a joke about this cup, right?
yeah, we gotta get a little something while people coming on. Yes.
Yeah. So this cup now is was a gift from one of
Uh,
my patients, right? So it's a unique cup because it's actually black.
mm-hmm.
But whenever you add hot beverages to the cup,
Right.
it actually has this picture. So I got this cup I had it for probably a couple of months,
Mm-hmm.
before
Right.
using it.
Right.
So I had a black cup. And so one day I saw the cup and I said, I've never used that cup. Let me use it. So I poured some tea in it, put the tea on the table, and
Right.
went away. When I came back, Doc, I'm
Yes.
looking at the table and I'm seeing I don't see the black cup. I see in a cup with my face on it and all these
Oh
things.
my. Wow.
I'm starting to wonder now. Because I have another cup that another patient gave me with the same image. I'm saying I'm
Right.
sure it was a black cup I was using. So I was
Right.
wondering if I was losing it.
Right.
Only to realize that the cup
Yes.
changes color with temperature. So
Oh.
so when I'm using this now, I know exactly how long we're talking by when it starts turning black.
Okay. Okay.
So once it,
Okay. Wonderful. Wonderful.
so you'll see it as it goes on the show goes
Right.
along.
Awesome. Well, I gotta get one of them. I don't know how much for it, but me and Bishop Leroy needs to
I
get
don't
one
know.
of that.
I
One
don't
of
know. I
them.
never had that before.
Praise God. Once again, I want to say hello, hello, hello to all of you out there. Man, I just want to say how much I appreciate all of you for taking the time out to really come on this webinar. And as you can see showing on the screen, it's just the beginning. I know that a lot of you are familiar with my program, Real Talk, that I would have been doing with special guests, and we bring in all kind of people. But I think the time has come for us to come back and definitely be on. And I just want you all to know that we're going to be featuring persons on the screen from time to time, but I will review I will be reviewing, all that is coming, all that is posted, because we're not going to be allowing any spams to be here with anyone promoting their agenda or anything like that. We're not going to be having anything like that. So, we will be critiquing all of the text that you send in. So it must stay in line. And don't forget, tell me where you're coming in from. I see Jamaica in the house. I see Sister Sandra Cafe. I think she's at the HSA also. Yes, Sandra. Yes, your good friend there, Dr. Leroy. Yes, from the hospital. Yes, and so we really want to. I see Portmore in the house. Yeah, man, this is awesome. I see some of you. We're just taking a little time out to welcome all of you, because I'm going to be kicking right in, and then we'll do some more at the end. I see Jamaica. Yes, tell me where you're coming in from. Tell me where you're coming in from. That's right. We want to know where you're coming in from. Some of you, I'm not sure. I just want to say welcome, welcome, welcome. Awesome, awesome, awesome. All right. Doc, I know we're going to be looking at a powerful topic, polycystic ovarian syndrome. I am familiar with it pretty much and has vast knowledge about it, but you're the pro. You are the pro. And so before I get there, what I need to do now is do a little introduction. I'm going to be giving you all a little introduction about Dr. Campbell. So I hope you're ready for it. It won't be everything, but it's going to give you enough for you to understand who we have and how much we should appreciate him. Because something like this, and to get a man like this, a renowned speaker internationally, locally, internationally, I mean, you're talking about as far as China. Yeah. So we just want you to know who you have here on the program. So Dr. Campbell is a specialist obstetrician, gynecologist with a strong passion for teaching and great patient care. He's a true, kind, and compassionate and empathetic caregiver. Dr. Campbell's special area of interest, though, is maternal fetal medicine, an area of obstetrics that deals with very high risk pregnancies. Yes, you heard me right. This is the man. The whole Cayman Islands is running down this man. He don't have hands. Yes, so he deals a lot with maternal fetal medicine, an area of obstetrics that deals with very high risk pregnancies, whether due to pre-existing maternal diseases or fetal complications. I'm telling you, the Cayman Islands government is blessed to have a man like this on the island. With almost 2 decades of service to the health system in Jamaica, Dr. Leroy Campbell has made tremendous contributions to the field of women's health. And, he's dubbed as, this is what he's dubbed as here in Jamaica and worldwide, the women's health doctor, and also Dr. C. And you will see there on his title. He has also served as a tutor and mentor to numerous undergraduates and postgraduate students during a decade of service, more than a decade, as an associate lecturer at the University of the West Indies, as well as a consultant physician in public service. He has been involved in several landmark initiatives. Guys, I want you to listen to this. I want you to listen to this. This is a man that has his own practice here in Jamaica, believe it or not. Skyline, that's right. Major, awesome practice. And he has given up a lot to come and serve in the Cayman Islands. It's not about the money, I can tell you that, because here in Jamaica, this man makes good money. So I want to make that clear, because sometimes we tend to want to say, oh, it's because of the dollars. This man has his own buildings with associates. Okay, so listen to this. He has been involved in several landmark initiatives and surgeries, including two of the first, you heard me right, two of the first successful surgeries performed on an unborn baby in vitro. The baby's still in the womb. And this man was a part of a major surgery, the first of its kind, made history in Jamaica and the Caribbean. You know, there is so much more that I could tell you about this man, that the whole program would be just on all of his studies. But I'm just going to say this much. He presently serves as a consultant and surgeon in the Department of Obstetrics and Gynecology at the HSA, which is the Health Services Authority of the Cayman Islands Government Hospital. He's married to a doctor, yes, like-minded. He's married to Dr. Glendy Campbell, and I can say this much. Both of them are God-fearing, and it's a God-centered couple. And so, giving you just a little piece of his education, his fellowship in maternal and fetal medicine, Department of Obstetrics and Gynecology, University of the Hospital, fellowship, American College of Obstetrics and Gynecology, doctorate of medicine and obstetrics, University of the West Indies. But there is something that I want to share with you. He's a man also believes in integrative medicine. He has done training, traditional Chinese medicine training as a manager for developing countries. That's right. In Beijing, China. And so without further ado, I am going to allow Dr. Leroy to come on and just, take it away, Doc. It's all yours. Go ahead and take it.
Yes, good night, Doc. How are you? Once again, my immense pleasure. I know we've been planning this for some time now. The intention was for us to get together on an occasion like this to chat and to see how we can share with others. And I am so grateful to finally have gotten the time for us to make it happen. So welcome everyone, and hopefully the things that we're going to be talking about tonight will be of help and assistance to you. And if you have questions, don't be afraid. This is the time to post them. So, Doc, you lead and I will follow. You lead and I'll follow.
Well, we're talking about polycystic ovary syndrome, PCOS. And this is the man that, trust me, you would have seen him, some of you on Instagram. He has also hosted his podcasts on Apple Podcasts, on Spotify, also in nationwide radio network, and here in Jamaica, highly sought after, as I've said before. And so I just want to say, I have a few questions, Doc, but it would be good if you can just lead off with your vast knowledge, and then I have a few little questions. It's things that things that I know, and then I'll be dipping in also. But I think the people has come on this platform to hear you and not so much me. You understand? So I'll just stay in the background and just allow you as I put up some people and just, give them that, recognition. So I'm just going to leave you to take it away. And then while you're talking, I'll come back on.
Yeah, no problem. Thanks, Doc. And, it's a privilege and an honor, as I've said, to come to share. Dr. Fagan is a good friend of mine, really good, God-fearing woman, somebody who loves the Lord and also loves people, and spends a lot of her energy trying to build others and to enhance the quality of life for other persons. And that is right upstream with my passion, which is to help women, to empower them to live happier, healthier lives. And I think one of the best ways to do this is through the provision of high quality health education. So tonight we're going to be talking a little bit about polycystic ovary syndrome. And anytime we're going to be talking about a topic, one of the first things we have to do is to define it. So what is polycystic ovary syndrome? And polycystic ovary syndrome really speaks to a metabolic condition that arises as a result of the effects of high levels of insulin and insulin resistance. And it has the capacity to affect all different body systems, but typically presents to us as gynecologists with symptoms such as irregular periods, issues with increased testosterone, such as hair growth, as well as acne, etc., and fertility issues. And it's a very common condition in actual fact. It's estimated that somewhere between 10 to 15% of women, usually the statistics would say 5 to 10, but the numbers are increasing. And now in some populations, as high as 15% of women are affected by polycystic ovarian syndrome. For the purpose of this talk, we're going to be just using PCOS for short. So instead of saying polycystic ovarian syndrome, we're just going to be saying PCOS for short. Okay. Now, why is it important for us to talk about it? It's important for us to talk about it because, one, it's very common. Two, this is a condition that has significant effects in a woman's menstrual cycle, which can affect her quality of life. Three, there's a condition that is associated with fertility issues, and so can be as one of the leading causes of subfertility or infertility. Four, this is a condition that is associated with a myriad of other systemic diseases, ranging from diabetes to hypertension, high cholesterol, and even psychological disorders such as depression. And women with polycystic ovary syndrome are at significantly increased risk of even suicide. And so, if you think about it, then this is a condition that has significant far-reaching effects. And so it's very imperative for us to understand about this condition if we are going to really transform the health situation for most of our women. Okay. So what causes polycystic ovary syndrome? What causes polycystic ovary syndrome? And the classic example that I would use of a patient with polycystic ovary syndrome is usually a woman who starts out, a young woman who is, perhaps thin or, normal body habitus. And over time, she starts to put on weight as she gets older. So usually a thin as a child, and as she goes into the teenage years, she starts putting on weight. And she finds that her periods now become irregular. And so there'll be times when she'll miss her periods for months at a time. And then when the periods come, they may be coming as spotting or, in an irregular fashion, unpredictably, or sometimes they'll come as heavy bleeding and prolonged bleeding. The underlying issue really is that there is an issue with a hormone called insulin. And insulin, most of you will be familiar with insulin in the context of diabetes. All right? Because we know that insulin is a hormone that helps to reduce blood sugar. Okay? So, because insulin helps to reduce blood sugar, then we are familiar with it as a treatment for diabetes. But we must understand that native to our body, inside of our bodies, we're actually producing insulin all the time. It's a necessary hormone for us to stay alive. So whenever you eat a meal, for example, that is high in carbohydrates, or you have a drink or something that has a lot of sugar, what happens is that sugar is absorbed into your bloodstream. And when that hits your bloodstream, it brings up your blood sugar. Now, if the blood sugar remains high, it can be dangerous to your body for many reasons, which we won't get into all of it today. But your body responds by trying to bring that blood sugar down. And how it does that is to move that sugar from the blood into your cells, into your fat cells, and to store that sugar as fat. And that action occurs because of the effect of that hormone, insulin. So, insulin is responsible for moving that excess glucose from the blood into the fat cells to be stored as fat. And that's how it controls your blood sugar. Now, imagine for a moment that you chronically or you're constantly consuming high quantities of carbohydrate. All right, you're eating lots of bread and rice, cakes, pastries. You have your juices, that have lots of sugar in it, or high fructose corn syrups, sodas, mixed drinks, having lots of sweet fruits. Then you will realize that your body is going to be constantly producing high levels of insulin. And that insulin is storing that glucose as fat. So we're going to start putting on fat. Okay, that's how we gain weight. That's how we put on fat. Now, one of the problems is that the more your body stores fat, the less sensitive your body becomes to the insulin that you produce. So what then happens is that your body responds by producing more insulin in order to reduce that blood sugar. And over time, you develop high levels of insulin in the bloodstream, a condition we call hyperinsulinemia, high levels of insulin. Now, it is this excess insulin that creates the problem, because this excess insulin now begins to affect other tissues, not just our fat cells, but it begins to affect other tissues in the body. Because guess what? Guess what? There are insulin receptors on almost all the tissues of your body, all the cells. So it begins to affect these receptors all across the body. And one of the places that has lots of insulin receptors is the ovaries. The ovaries. If you're looking at the screen to my right side, or rather on your screen is going to be to your right on the screen, and to my left, you're seeing an image of the uterus. And beside it, there are these two oval shaped structures. These are called the ovaries. And the ovaries are what are responsible for producing the eggs that eventually are fertilized to give rise to a baby. But they also provide a significant function in producing hormones like estrogen and progesterone. And they secrete these hormones in a cyclic fashion that stimulates the lining of the womb to grow and then shed each month. So each month the lining grows to facilitate an egg if it's fertilized. And if it's not fertilized, then it sheds after 14 days. And that comes out as a period, and the process starts over again. So these ovaries have insulin receptors. And the high levels of insulin can now begin to stimulate those receptors on the ovaries. Guess what happens when the ovaries are stimulated by insulin? They start to behave in an abnormal pattern, and they start secreting different hormones in different proportions. So, for example, they start secreting high levels of a male type hormone called testosterone. And this testosterone is why women with polycystic ovary syndrome, for example, will find that they develop acne. Sometimes the skin is very oily. They may develop male pattern hair growth. So sometimes they'll grow hair on the chin or a mustache. Some women may experience male pattern balding. Their hair beginning to fall out in different parts of the scalp. So they begin to go to lose hair. And this is all because of excess testosterone production from the ovaries. All right, so we're beginning to see the process by which polycystic ovary syndrome affects, or PCOS affects, the body. Now, another thing that happens is that this excess testosterone also affects the development of the eggs in the ovaries. So every month, the ovaries would normally produce a cohort of eggs. Several eggs develop, and eventually one is released, a process we call ovulation. And ovulation is where that egg is released in preparation for it to be fertilized by sperm and for pregnancy. And that happens once, usually every month, for a woman who has a 28-day cycle. Now, can you imagine if it is that these eggs are not developing, they're trapped, they get trapped in a phase of development, they're not being released, and so they begin to collect along the borders of the ovaries. And they form little cysts along the borders of the ovaries. And that's where the name comes from. Because on ultrasound, when you look at the ovary, typically the ovaries will have these many little cysts along the borders. And the word poly means many, cysts. Okay, so that's where the term polycystic ovary comes from. Many polycysts, many little cysts along the periphery of the ovary. Okay, polycystic ovary syndrome. And it was this observation that caused practitioners and the original describers of the condition to coin the phrase polycystic ovary syndrome, because they saw these many cysts along the ovaries. So they thought that, okay, this is the cause of the problem, but actually the polycystic feature is a result of rather than a cause. So we know that now, right? Because these eggs are trapped and not being released. So you can imagine, therefore, that if a woman is not ovulating each month on a regular basis, all right, then that's going to have some implications. What are these implications? The first thing is that you can understand if the egg is not being released, then it's going to be more challenging to become pregnant, because you need the egg to be released to be fertilized, to form the embryo, which is going to form the baby. So if the egg is not being released, then it's going to pose a challenge. Now, many women, and it's very important for me to say this, because many women with polycystic ovary syndrome have been told they cannot get pregnant. And I need to deal with that myth. That is not true. Polycystic ovary syndrome does not mean a woman cannot get pregnant. It may mean that it may be more difficult, but not impossible. And the reason is simply this, is that women with polycystic ovary syndrome may not ovulate each month, but it doesn't mean they don't ovulate at all. So if, for example, under normal circumstances, a woman ovulates on a monthly cycle, she's going to have 12 eggs released for the year. She has polycystic ovary syndrome and she's not ovulating every month. Let's say she's ovulating once every 3 months. She may have 4 eggs released per year. So it means her chances of getting pregnant are significantly reduced, right? Probably 1/3 that of compared to the woman who is ovulating every month. So if you understand that, then you can understand that polycystic ovary syndrome is associated with difficulty getting pregnant, but not it doesn't mean that the woman cannot get pregnant. So that's the first thing. The second thing that we can extrapolate from the fact that the woman is not ovulating is that the cycles are going to be thrown off. So you're not going to be going through that monthly cycle, which means that you may find that there are months that you'll miss a period. 2-3 months, you may miss a period. And during that time, the lining of the womb is just growing and growing. And eventually, it may break off, and you have patches of it breaking off, and you may see some bleeding, but it comes irregularly. So the second feature now that we're seeing here is that irregular periods. Okay? And over time, if not addressed, that can increase the risk of many other factors. But I want to stop there for a moment, because I want to So I'm going to go on to give a chance for a little discussion. But so what do we need to diagnose? I've given you enough for you to understand how we diagnose the condition. So to diagnose polycystic ovary syndrome, we need two of the following three things. One is that there is a history of irregular periods or abnormal periods, right? Indicating that there's lack of regular ovulation. Two, there's evidence of excessive testosterone secretion. So that is acne, facial hair, okay, balding, male pattern balding, other features indicating testosterone excess. And three, there's evidence of polycystic ovaries on ultrasound. And if you have two or more of those three, then the diagnosis of polycystic ovary syndrome can be made. All right, let's break right there. Doc.
So, Dr. Campbell, um, basically, as I'm listening, like I say, I'm familiar with it and I've seen a lot by working in theater over the many years at the hospital and what have you. But for the edification of the people, and I can see everybody's just appreciating it. Some of the things too that we got to understand is that a lot of folks in the church, they don't know the power of being educated on this level with these kind of things, because we know, and as a MD, and me being a naturopathic, it doesn't matter. As pastors, we know that there are women who are in our churches also bleeding, things happening to them, and they're suffering secretly, silently. And so this is awesome. And I can see the response that we're getting from persons, like I say, we feature them while we're live, because once we go off, we won't be able to do this kind of thing. But some of the indicators of PCOS also is fatigue, low energy, right? As you said, the thinning of the hair, the unwanted hair growth, the little balling in the middle of the hair. And you talked about the weight gain. And we know that a lot of it normally collects in the abdomen, belly. So that belly fat, that visceral fat. And I know that as you were sharing, you were talking about the insulin resistance, and that's the major, and insulin resistance cause so much other things that people don't understand, that insulin resistance is something very dangerous. People think that because I don't have diabetes, maybe you just want to touch on that, because that is something I remember many years ago. I were doing some products, and one of the things that I learned had to do with the weight gain. A lot of times, the stubborn fat has to do with insulin resistance. So you want to just do that as I just share one or two.
Yeah, thank you so much for that. Because, so first of all, yes, definitely when you talk about fatigue, even emotional lability, women having mood swings and all these things,
Right.
because the whole process can affect, as I mentioned before, every system in the body. So from the brain all the way down. Now, I want to focus and zoom in on that insulin resistance, because I think it's so important.
Thank you.
Now, what we have to understand, friends, is that when we talk about diabetes is the end point of a process of metabolic dysfunction that starts years before you're diagnosed with diabetes.
Right.
So by the time somebody is diagnosed with diabetes, they have had insulin resistance, for example. And we're speaking to type 2 diabetes.
Yes.
Because remember now, there's type 1, which is primarily related to deficiency or inability to produce insulin.
Right.
Now, type 2 diabetes is a product of insulin resistance. And what is happening is that we as a population generally, and this is cross borders now. You have people online
Yes.
from the US, you have people from Jamaica,
Canada.
you have people from Cayman, you have Canada. This rule
All over.
applies to all of us, that we are in a society, in a time where there's chronic overconsumption of carbohydrates. All
Yes.
right?
Yes.
Chronic overconsumption. Remember now, for thousands of years, when our ancestors were living, whether it's in Africa, in Asia, in the Caribbean, we they didn't have access readily to food sources. Eh?
Right.
Remember, sugar, for example, is something that is about 200 years old.
Yeah,
To be able
because
to
it
process
was
and
natural, it was keen.
the only way you had sugar in the past was by eating some fruit, right?
Exactly.
Until we learn how to process it and use it as crystallized sugar.
Yes.
So people really weren't consuming carbohydrates in the way that we're consuming now,
Right.
right? Over the
And
last 100 years.
all the artificial sweeteners, you can see that we're onto something good, because a lot of people don't know that even those artificial sweeteners, they're more dangerous for you. The people will say, well, I drink in diet soda, and I drink it, and they don't even know. But that's another topic right there. But as you're on this whole sweet stuff, wonderful.
No, you're absolutely right. So we have all of this sugar from that we're eating, not to mention what has been happening to the processed foods that we're eating, right? Um, so we're eating more sugar than ever before, and when we're looking at the consumption, what we in the 1900s, what would have been consumed um, over in terms of sugar over the course of probably like a week,
Hmm.
we are consuming in one beverage, okay? And the average, when you look at the rates of glucose consumption
Hmm.
over the last 100 years, we're probably going up to 10 times more, even among the
Wow.
conservative eaters,
Hmm.
more carbohydrates than we have had in the last 100 years. So what does that mean? It means now our body, remember now, back in the day, if we go back in the time machine, we get up in the morning, we didn't have access to breakfast, right? We had to go out and hunt, or we're going to have to gather from the farm, and we're going to have to put together a meal, right?
Right.
So it means that the average person would probably have a time where also for the entire day they may not eat. And if
Yeah.
they eat, they might eat one meal a day. And so what your body would do is that whenever you do eat, it would release insulin to
Hmm.
help to store the excess sugar
Right. Right.
as fat, so that when fasting
And people
comes,
were more active. We didn't have cell phones, and we didn't stay on the couch so long. We had to get
right,
outside and move and sweat in the sun.
and
And
you have to
so,
work, you have to
yeah.
do physical work. So your body is designed to store fat for whenever there's no food available. Okay.
Hmm.
Now look at what is happening now in our society. There is no time when we're without food. Because now we move from eating one meal a day to one meal every other day to eating 3 meals a day, plus snacks in between. So now you're constantly secreting
Okay,
insulin.
Doc, I'm gonna get back. I know that that's his wife. This is awesome. This is what we're talking about. Say something. I
What's that?
see. I know that sister. That's Sister Grant, but maybe her phone is not functioning. Her husband, she's writing it on her husband's phone, and it says, "I was given metformin to ovulate, but still could not ovulate." Here is someone trying to get pregnant. A couple. So, it's just to show you that we have persons on here who are really going through this. And, so go ahead with what we're trying to do, guys, and Doc coming back in. What we're trying to do is to educate you to the root. We're not saying that because I think Doc would correct me. There is no real full scientific um, thing to what really causes this, but they have come up with insulin resistance. Am I right or wrong, Doc? That
What's the
triggers.
question? What's the
No,
question?
no, I am trying to say that in studying, they don't really know for 100% the real root cause of polycystic ovaries, but they have, with all the research, come to a conclusion that insulin resistance is a trigger and can, be a cause of it. Am I right or
Yeah,
wrong?
certainly. Yeah, certainly. Yeah, that's one of the main factors. Main factors. What we don't know is why some women develop it and why others don't. But we
Right.
know as a fact that ultimately insulin resistance is a major factor.
Right. And you talked about, so also with, is it possible for a woman to have polycystic ovarian syndrome and did not go to the doctor, seeing these irregular periods and just thinking, well, it's probably because I'm stressed out, which stress, can help make it worse. Um, what would you say about that? Because person is not sleeping, is not having difficulties with falling asleep and the lacking of melatonin, because we know that melatonin is naturally made in the body too, but that's another story. We we so messed up that half the time, we're not, able to produce it in the amount that we need. But does PCOS affect your sleep?
Yeah, absolutely. So PCOS can affect your sleep, and also your sleep issues can contribute to PCOS, right?
Mhm.
Because
Oh,
one of the factors that's important to recognize is that whenever we're deprived of sleep, doc, it
yes,
stimulates the release of a hormone called cortisol. Okay,
cortisol. Yes.
right, and cortisol is a stress hormone,
Hmm.
and what cortisol does is that it actually increases insulin resistance. So persons who have high cortisol levels over time develop insulin resistance. They develop more of that visceral fat that you're talking about, the fat
Right.
around in the
In the
in the
abdomen.
tummy,
Yeah.
around the
Hmm.
abdomen. Some people notice some fat in the back of the neck here,
Yeah,
that they
stubborn
just
fat, they
can't,
call it.
they
Just
can't, yeah, they
can't. You go
can't
to the
shake it.
gym, you go to
They
the
lose weight.
gym, you exercise, you change the diet, you're doing all of these things. This is very good. See, someone said, let me put it up again. Someone said very informative, because people will say, I go into the gym, I working out. For instance, as we age, as we age, we know that the body, the metabolism is not the same as when we were in our 20s and 30s and what have you. But there are still some of us, like for instance, people that say to me, oh, Dr. Fagan, you look so nice, and this stuff. I say, but I got one little punch here now. I got one little punch, I got one little bit here. But you have persons that is young. So this is not something that people can say, okay, this is just for people at a certain age. When is the start of, when does this most times that this would start, from your experience? What age
You mean
group?
in terms of
Because we
polycystic
know
ovary
about,
syndrome?
yeah, because
Okay.
we know about menopause, roughly, but or this can start as for the teenagers. Um,
Absolutely, yeah. So probably if we were asking this question, let's say about 10, 15 years ago, we're going to be saying it's starting in most women in their late 20s or early
mm,
to mid to late 20s.
right,
Um, Now we're saying that you're finding it starting younger and younger. So in fact, you're having teenagers who are coming in with polycystic ovary syndrome, and
right,
that is directly correlating with the trend towards obesity
right,
in the population.
right.
Because as we mentioned before, increased body fat percentage, insulin resistance is a trigger.
Hmm.
So as the population has a greater propensity towards being obese and overweight, then we're
Hmm.
finding polycystic ovary syndrome occurring younger and younger.
Right, right. All right. Let me ask you this now. Um, is there anything that a woman can take from your experience? We know that you have the metformin and you have some other clomiphene and different ones that sometimes doctors will prescribe. I don't know if that's the same name for the other one. But is there any type of surgery or so that a person who is trying to get pregnant and they've tried everything? I mean, as you said in the beginning, um, yes, they say about a woman can't get pregnant, but I've seen men and women got pregnant when they least expected. So, is it also does anxiety of wanting to get pregnant so bad? Can anxiety not be something that could hinder? Which because I remember that there was this lady who were trained like for 10 years to get pregnant, and she came and she did 3 sessions with me of colon hydrotherapy. And after after the third session, um, Deaconess Powell is on. After the third session, it was like 2 months after she came by, rejoicing, all excited, and say she's pregnant. And I was doing some research, and one of the things that I found out also is that with an impacted colon, with constipation, and the colon disproportionately might be resting against, the reproductive organs, male and females, that can also play a role also with even with toxicity. Now, I can't tell you what happened if she was more relaxed or she believed in psychologically that, after I done this, because, the mind is a powerful thing, and it was about maybe about 2 or 3 persons that got pregnant, and they were told that they couldn't get pregnant. And I would have done some counseling with them. As you know, some people might not know, but I'm also a certified Christian psychotherapist. You hear about psycho, it's not what you're thinking. The Bible talks about renewing the mind. You understand? The Bible talks about renewing the mind. And we know that you also talk sometime about seeing a psychologist different from a psychiatrist, right? So, after talking with her, I said to her, when you go and your husband go in together, relax. Try to relax. Oh, well, she said, Dr. Figan, it's not that easy because my mind is just saying, I wish that I could get pregnant. So she go into sex. We're big people here. She go into sex with already being tensed of, so I had to say, listen, just go and just relax yourself. Try and time your ovulation. Yes, you might not know exactly when it's going to come, but there is a time when you just have to just take some risk and just try to see if you can pray that it happened within the time it did the last time, and then you hit it. I hope nobody don't take a backslide though. Help me here, Doc. Bless these people too. But this is what it's all about, real talk. Do you understand?
Right. Yeah. So the question is,
anxiety.
what?
If people is
Oh, you
anxious,
mean?
it's
Yeah. So anxiety certainly can play a role in fertility. There is good evidence to indicate that a woman's mental state can have an effect on hormonal function and fertility. In the case of polycystic ovary syndrome, apart from the anxiety, we as I mentioned before, the lack of ovulation is the major factor that is responsible for the challenges these women have in conceiving. When we talk about treatment, of this condition, the treatment is two-part, right? So we're talking about root cause treatment, in other words, addressing the underlying disease itself, because
Right.
the majority, guys, listen, the majority of cases of PCOS can be reversed, totally reversed.
I
It is
agree.
not a condition. Almost all cases of
Yes.
PCOS can be reversed totally. So
Yes.
there is really the underlying approach to therapy that is focused on the root of the disease, and
Hmm.
then there is therapy that is dealing with the symptoms
Hmm.
or complications
Complications
of
of
the
it.
disease. Okay.
Hmm.
Um, Now, when you're asking me about fertility, my approach is both sides. So it's not just about medications. It's about let's just try and deal with the root of disease. So
Well,
the
well,
kind
you're
of
integrative medicine, so you're
right,
into integrative
right,
medicine too.
and that's very important because you see, we can always use medications to allow a woman, for example, to achieve her goal of conceiving. But remember now, the best gift you can
Complications.
give to your child is yourself. So if you're
Yes.
coming into pregnancy and you're not healthy, then you're increasing the risks related to that pregnancy, a risk of having adverse pregnancy outcomes. So
Right.
dealing with your overall health is also a key part of
Right.
optimizing yourself to have a good pregnancy outcome. And the
Yeah.
studies show that if mommy is healthy, it
Yes.
programs a healthy baby. And if mommy is unhealthy, the programming for disease starts as early as conception. So very, very key.
Yes. And that's why you're so highly sought after, doc, because of you. We have what we call conventional or allopathic medicine, which, as you're a trained medical doctor, university trained and everything, and most times, as you say, surgery, drugs, but then you went on to also train into integrative medicine, Chinese medicine. So you have this knowledge of conventional medicine and integrative medicine and or alternative medicine, so that you is now a doctor that yes, you're going to do what you got to do, but at the same time you want to get like myself as a naturopath, as a naturopathic practitioner. We don't just want to focus on cause. We don't just want to focus on symptoms, because as you said, you can get the medication, you can get all the drugs, and it suppress, but it does not heal or cure. The problem is still there. But if you get to the root cause of the problem, then you will know how to treat the problem from the root, from the root. And then, as you say, mother and child is healthy. Now a question is asked, and I'm going to put it back up. How do you know if you are insulin resistance? Do you have to do a blood test? Are you seeing the text too, doc? Are you seeing it on your screen?
Yeah, when you put it up, I'm seeing it.
Yes,
All
well,
right.
it's there.
So
Okay.
before I even answer that question, it's important. So my training is not as a Chinese medicine practitioner,
I know.
but from an administrative standpoint. But I
Standpoint.
do. But you're absolutely right in terms of one of my passions is really the integrative approach to medicine,
Hmm.
because what we have to do, we have to deal with the root cause of issues.
Yeah.
If as long as we're just dealing with symptoms and using medications, we're really not solving the problems that we really
Yes.
need to be solving. Um, regarding the question of
How do you
insulin,
know? Yeah.
right, of insulin resistance. So when we talk about insulin resistance, there are clinical features and there are biochemical. So there's stuff that we can know just by looking,
Mhm,
and there
mhm.
are things that we can find out by testing. And I'm going to
Right.
start with the clinical features first, because you may be able to look at yourself and begin to see some of those features.
Yes.
So for example, how you feel, symptoms. We
Yes.
spoke about lethargy. We spoke about
Yes.
that chronic
Sleep,
fatigue.
sleep, and
Right. We spoke
mood
about the fact.
swings, mood
Right.
swings. You know.
Right. We also recognize that sometimes cravings. So you'll find that persons may have intense cravings,
Wow.
especially for sugar
For
and
sure.
for sweet things.
Things.
Um, some persons may find that, especially at nighttime, they find themselves craving a lot and they're eating late at night. A lot of the times, these are symptoms of insulin resistance. You have
Right.
something to eat, and the next thing you know, you're feeling within an hour or two, you're hungry, and you have to eat something again. All right. So these are all symptoms. Then you have signs, and signs are really what we can see. So, for
Yeah.
example, one of the classic signs, almost every time you see this, you can guarantee the person has insulin resistance, is what we call acanthosis nigricans.
Mm-hmm.
And acanthosis nigricans is really where you get this velvety pigmentation, like dark
Oh,
pigment,
yes.
sometimes on the back
I
of the
see
neck,
that.
sometimes
It's
on right.
true.
Sometimes, persons will say, "Boy, your neck dirty. You need to wash your neck." But it's not that the
Wow.
person's
It's
neck is
true.
dirty. It's actually that there's pigment being formed there. Some people may actually see it under the armpits, okay, and in
Wow.
different areas of the body where you have creases. Um,
Mm,
that's called acanthosis nigricans.
mm.
And you may also notice other things. So, for example, acne is actually one of those things that could be a feature of
Right.
insulin resistance, right?
Yes, yes.
Especially in women. Okay.
Right, right.
Um, then you also talk about skin tags. A lot of the times you see these little mole, little lumps growing off
Mhm.
on the skin. We call the I know I'm trying to find the
Well,
colloquial
I got
term.
one or two, so I hope I ain't resist. Let me check
Yeah,
myself.
yeah. Don't worry, I have one right here myself. So
Yeah, but
skin
I know
tag.
what you mean. Yeah, but you
Yeah,
have some
yeah,
people that is full of it. Just
yeah,
the little skin
yeah.
tags. Yeah,
Right.
yeah, those
So
little
lots of
things.
these
Yeah.
little
Wow, this is so
right,
educational, though.
right.
Go
So these
ahead,
little
doc.
papillary projections are
Wow.
oftentimes signs of insulin resistance. How the person's physique appears. So we spoke about what the medical term is centripetal fat distribution, which is
Mm-hmm.
fat in and around the trunk. So you have
Mm-hmm.
people sometimes the legs might be skinny, they don't have a lot of fat on the legs, but the tummy is protruding.
So you have like a
Um,
pear, like a little pear, like a little pear,
no,
pear
not
shape.
pear, but more like we usually use apple. Apple as a description, apple shape.
Oh,
So pear shape is like when you have,
because I
most
saw
of the
some
fat in the
shape.
thigh and the buttocks, which is not bad.
Oh, no,
Actually, that's more
we just
healthy.
talking because we helping people. It's the truth.
Right. So pear shape is usually considered more healthy. So fatting around the buttocks and the thighs and so forth. Apple shape now, which is where you get fat in and around the trunk, the belly and the chest and so forth, and the
Well,
legs are
Jesus have
skinny.
mercy. We can't be looking like bones now. So what is the bone shape? What was
No,
the?
no, there's no bone. I don't know any bone
It's
shape.
getting a little humor
I
here.
have apple and pear. Yeah, so the where the fat is distributed is also important. Okay, gives you
Yes.
some clues. And then the question is about whether or not there's blood tests. Yes, there are tests that we can do. So first of all, what's the blood sugar doing? That's the cheapest and easiest test. All right, not necessarily the most sensitive. So there's a test called HbA1c, and
Mhm.
HbA1c allows us to see what blood sugar control has been like over last 3 months or so. So it
Right.
gives us an average of what your blood sugar is like. We
Right.
can also do tests of the fasting and sugar and what we call postprandial sugars.
Right.
Sugars after you eat to see how your body responds to that.
Yes.
And as well as after taking in some glucose. We call that a
Right.
glucose tolerance test.
Mm.
And
So
then to
repeat how
increase,
we repeat that is something that they have to go to a lab for, though. Is
yeah, so most,
so what about at home sometimes if you went on your fat, what about your regular little your regular little prick on the finger, your little test? Would you get anything with doing something like that? And when you're finished, we have some questions more on the thing. But
sure, yeah.
do you the
The
stick
finger prick test is,
is not
is not
as
as useful unless, because if you're doing a random blood sugar, unless you're really already diabetic, you may not
oh
necessarily find that
yeah,
the sugar is abnormal, right?
okay.
Probably when we get into the more sensitive tests now, we start doing like insulin levels now, fasting and postprandial insulin levels.
Hmm.
But some of these tests can be expensive, doc. So
Yeah, I
what I
know.
what I want persons to
Yeah,
understand is that you
take
don't even
care of
have to.
yourself.
The majority of people don't necessarily even have to go as far as doing insulin levels. Once you go in the mirror and you look, Yeah,
common
and then think
sense.
about how you
You know,
feel.
that's what I like about you. You
Yes.
gonna try to get us to save some money now. You gonna get
Yeah.
us to save some money.
Yeah.
You're telling us the truth.
Save lives and save money, right?
Yes.
Yeah. So most of us, if we're really honest with ourselves, we can see that something is off. You know,
Yes.
when you were 15 years old, your belly didn't look the way it look now. You understand? Something
Yes.
is off. Something is off. It's just that we have come to accept certain things as normal.
Yes,
You know?
yes, 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 yes.
Mm.
I have a question here. Can PCOS cause cancer? And there was another one by Pastor, I think it was Pastor Black, asked the question, is PCOS hereditary? God bless you, Pastor Black. Yes. And then
Yes.
does it cause cancer? Is it hereditary? We got a lot of members on. We thank God
Sure,
for that.
sure.
Yeah.
Yes, you know, Pastor Black, thank you so much. I'm glad to hear you online. Happy to answer any
Denise,
question you
Tone,
have next.
everybody's here. There's so
Hi
much.
guys. Hello
Can't
guys.
keep up.
I guess this is Bible study for tonight, right?
Yes,
Um,
3 months on this. Yes.
yeah, the first question that is dealing with let's deal with the hereditary one first and then the cancer one.
Yes.
Yeah, when we talk about something that's hereditary, it's important that we classify what we're talking about. It
Yeah,
doesn't mean that if your mother has PCOS, that you must get PCOS. But there
exactly.
is clear evidence that there is a
Yes.
familial history is a risk factor and one of the most significant risk factors. And this is for two reasons.
Genes, genetic.
One is genetics, doc. One is genetics, meaning that we are programmed towards it, just like I mentioned from in the womb.
Mhm.
Two is the fact that we oftentimes mimic the lifestyle of our parents. So apart from being
Oh,
genetically predisposed, we eat the
yeah,
way our parents eat,
yeah.
we
Go.
behave the way our
We
parents
eat a
behave.
whole. We eat a whole cake. We
So
want a
yeah,
whole cake and 6 dumplings and all these stuff and putting
well,
on.
there you go. Yeah. And in the
Okay.
Caribbean, for example, if you look at the average Caribbean diet,
Wow.
it's over 70% carbohydrate. You see?
Mm,
So we consume a lot of carbs. And to answer the question about the cancer,
cancer.
absolutely. Yes,
Mhm.
PCOS is a risk factor for cancer, both directly and indirectly. So
Wow.
directly, PCOS is a risk factor for cancer of the womb. Because if you remember, guys, I
Mm,
mentioned to you that the lining of the womb isn't shedding regularly as it should. So it grows and grows and grows. And anything that is growing excessively can get to the point where it grows out of control and becomes cancerous. So
right.
PCOS is a major risk factor for endometrial cancer or what we call uterine cancer.
Right.
But it can also indirectly be associated with cancer because high insulin levels. So
Mm,
insulin is what we call a growth hormone,
yes.
a
Right.
growth hormone,
Mm,
which means that it stimulates cells to grow. So
right.
if you have like let's say you have a cancer cell, and our bodies oftentimes have cells that are potentially cancerous, but what
Yeah.
happens is our
Everybody.
immune system,
Everybody. Right.
all
Everybody.
right, but our immune system destroys them before they
Right.
can become cancerous. But
Right.
if you have high insulin levels, then the insulin will stimulate those cancer cells to grow
Mhm.
faster at a rate
Okay.
faster than they can be destroyed. And so
Mm,
high insulin levels is associated with higher risk of cancer. That's why obesity is a risk factor for cancer. Diabetes is a risk
right.
factor for cancer because
Yes.
of that fact.
And also, what about high blood pressure and heart problems and endometrial problems, which I know you spoke about the cancer. To what about those things?
Yeah.
How
So
how is that? A lot. So this is so educational as we're getting ready to soon come down, and just want to say to all of you, as you can see the ticker showing on the screen, other webinars coming soon, and if you'd love to have Doc back, this man has a vast amount of information. Doc, I don't know how you're going to manage it after this at the Georgetown
mm,
Hospital, because now everybody now is going to be to Dr. Campbell. Dr. Campbell, I'm going to stay send you to Dr. Campbell. You understand? But that is a good thing. That is a good thing, nevertheless. But
absolutely.
we're going to be coming in, guys, and I'm going to come back, Doc, with something else. We're going to be coming in, guys, with menopause. Yeah, we got to be looking at menopause. We're going to be looking at erectile dysfunction in men. Andropause is men. Erectile dysfunction, I think everybody, especially if you're married, and men, this is where we're going to draw the men on, where we're going to be talking about that, and how, when you understand, what happens to the body with a woman that is, premenopause, perimenopause, and full-blown menopause, whether it was surgical or because of the fall of the estrogen, and the men because of the testosterone, and all of those things we're going to be coming in with and talking about a lot of different things, mental health and weight control, and you're going to love it. So go ahead and subscribe to the channel, hit all on the bell, and if you're on Facebook, go ahead and follow. um Go ahead and follow, and just hit turn on your notifications so that you never miss it. And we want you to start letting us know how you have enjoyed this. How you have enjoyed this. Somebody say they went and done the glucose test. Awesome. So we want to hear from you. Now get in the chat, let me know if you enjoyed this. I know you did, but I want to hear from you. If you enjoyed this, you want to send a big up to Dr. Campbell, which some of you have started. Somebody saying great presentation, and we appreciate that off of Facebook. Wonderful, wonderful, awesome. So get in the chat now quickly and start leaving your comments. And what's the next topic that you would like me to come on with? We're going to pool some more doctors. I know that now that Dr. Campbell sees what it's all about also, he got other doctors that would probably want to come on and share on different topics, because I'm knowledgeable. I'm not an MD, but trust me, I am very, very good when it comes to anatomy and physiology, when it comes to a lot of these things as it pertains to diseases and medical stuff. I can tell you I'm very knowledgeable about a lot of things. And so I became the first Caymanian, probably is still the only Caymanian that was that had passed the Liaison Council of America exam, and became, due to my vast knowledge, because with diseases and surgeries and those kind of things. So I'm grateful to God to know that we can come with this kind of stuff. And so, Doc, before we go off, as persons are going to be just sending their vote of thanks, I want you all to tell me what's the next topic that you think is going to be mixed, whether it's menopause, whether it is erectile dysfunction, things not go on too well with the husband, things are flipping a flop. You understand? We're big people, we're grown people. Some of you will be able to share this video and help a brother or a co-worker, a friend, with all that have come here. So we want to hear from you. Go ahead and leave your comments if you have enjoyed this webinar. Doc, there was something that I wanted to ask you that I thought was very important. All right. We know also that, as I was doing my research and had some information over the years, we know also that apart from the drugs, we know that supplementation of vitamins and herbs, are also beneficial. What would you have to say towards that? For instance, what I found out also is that lacking vitamin D deficiency, is a lot of times found in women with PCOS. Vitamin D deficiency, vitamin D and calcium combination, those two. Also, some women with PCOS experience, heavy bleeding. So here you have some might miss periods while some have heavy bleeding. So here we have now the iron deficiency, and with the red blood cells. You want to talk and say something like that?
No, yes, absolutely. Thanks for giving me a chance to speak on that. So when we talk about nutrition and supplementation, as well as the use of herbal or therapies, they're one, just as we mentioned before, one to treat the underlying problem, and then
Yes.
two, to that may help to manage symptoms. So you mentioned iron, for example, which is primarily related to benefiting the patient in managing symptoms from heavy bleeding and abnormal bleeding, which can lead them to become anemic. Um, Certainly, vitamin D supplementation is an excellent tool. In fact, you know what, Doc? That goes beyond PCOS. To be honest, in my opinion,
I
almost
have to see
everyone.
this. Look on the screen. Look on the screen. Big up from mom. I had to interject there.
Oh,
Oh,
nice.
she's enjoying it. She's
The
enjoying
queen,
it.
the
Oh
queen is on. The
man.
queen is on. Good to hear that. Good to know that the queen is listening. Mom, love
Awesome.
you, lot.
Yes. God bless you, Dr. Mary.
Yes. Yeah,
Yes.
so absolutely. So vitamin D, because we have a high prevalence, and this is worldwide now, up to 50% of
Yes.
adults,
Right.
80% in some
Yeah. You don't have to
populations
have
are,
peacocks.
are
Yeah.
deficient in vitamin D because we're not
Yes.
getting any sunlight. We're inside most of the time. So definitely vitamin D supplementation is excellent for PCOS, but in general,
Mm-hmm.
there are certain. So, for example, one of the things that has become increasingly popular as a direct treatment option is something called inositol or maya inositol. And essentially, what that does, it's a metabolite which helps to improve insulin resistance.
Right. And
So,
what, repeat that
and
again? Repeat that again, sir.
inositol,
Mm-hmm.
right?
Yeah.
I
Right.
S I
Right.
T O
Yeah.
L,
No. Oh, yes.
inositol,
Yes. Yes.
myo-inositol, right? Or
Supplement. Yeah.
sometimes you'll see it as my-inositol, MY.
Right.
Um, right. So what we're really dealing with there is treating root cause now, dealing with the insulin resistance. And there is evidence to indicate that in the inositol, supplementation with inositol is almost equal to metformin in terms of its effects on
Mm-hmm.
improving PCOS because of that.
Mm-hmm.
There
Yeah.
are other herbal remedies that so you might be familiar with berberine, for example, which
Berberine.
is
Yes.
where-
Yes. Yes.
which is known to improve insulin
Yes.
sensitivity and
Yes.
treat
A lot of
insulin resistance.
diabetics. A lot of diabetics
Right.
take that. Yeah.
Yeah. So, and then of course, it's very important that we increasing our intake of omega-3 fatty acids, for example, which oftentimes we are deficient in
Right.
because we're not consuming healthy oils. We're using
Right.
probably too many seed
Right.
oils, and so
Right.
taking supplementation omega-3, or just increasing intake of olive
Even
oil or
even in
fatty fish,
primrose. Even
and
in
so right,
primrose. Yes.
right.
Mm-hmm.
So there are a number of other things that have been purported, but I'm sticking to the ones that there's evidence
Yeah,
to support.
that we know.
And
Even your bees. One of the things I'm an advocate for
yes,
your bees, your super bee complex.
right.
And I can see that people have enjoyed it. And you know what, guys, I'm so happy that that we could do this, that I could do this. And I'm glad that all of you appreciate this and appreciate Doc. Somebody say, wow, this is good stuff. You understand? So,
Mhm.
yeah. So we just want yeah, he talked about the omega-3, chromium, also selenium. Um, we talk about the inositol, and it's great. It's great. And so I just want to say to all of you, I don't know, Doc, if you have anything that I see some people asking for menopause next. No, that's up my line. So we can do that, or if you did you have a topic that that you did you have a topic that you think would have helped the body of Christ, people on a whole? Because there's a lot of Christians on here too, you know. And what would you say to someone who now, after you have made all, we have made all those description, what would you say now to someone who have PCOS now, and she's trying to get pregnant? What's your final words? the husband and wife or to that woman.
All right. Yeah. Thanks, Doc. So the first thing is lifestyle. The first thing you want to do is to address your nutrition by reducing carbohydrate intake. Focus your diet towards fats, proteins, fibers. Ensure that you're getting regular exercise. Doesn't have to be anything great. Just walking once a day for half an hour is fine. The main focus is going to be on reducing your carbohydrate intake. All right. So fat, fibers, proteins. Then now, if it is that you're looking to get pregnant, you may need some assistance from a medical standpoint. Sometimes just the lifestyle change alone is enough. The
Yeah.
evidence shows that even a 5 to 10% body fat weight loss can reverse PCOS in most women. So just
Yeah.
5 to 10% weight loss can reverse PCOS in most women. So sometimes
Wow.
if you're focused on the lifestyle changes, that alone is enough. But then
Wow.
now, sometimes you're going to need some help. And this is where persons like myself and other experts in the field come in, because now we can also provide you with medications that can help you to
With
ovulate
the
more
weight
frequently.
loss, with the weight loss
Well,
to help.
yeah. So with the weight loss, but also to help to ovulate. If pregnancy is the ultimate goal, and in inducing that ovulation, of most times women can become pregnant. Sometimes we use the metformin alone. Many women can't really tolerate metformin because of the side effects. Okay.
Yes.
But it works quite well. It also helps a little with weight loss, and it does help ovulation in some cases. But
Yes.
we have medications specifically designed to stimulate ovulation, and I've seen many a patient. It's very rare I can recall a patient. In fact, I can recall a patient that I've seen trying to conceive who has not been able to conceive if the issue was just purely PCOS alone. So the prognosis is excellent for most women who have polycystic ovary syndrome who are trying to conceive.
Yeah, because I know that one of the surgeries is LOD, laparoscopic ovarian drilling.
Drilling,
But
yeah.
then that has also its own problem due to, sometimes, not always, because I've participated in that, and scar tissue on the
Yeah.
ovaries
So
post-op.
one of the reasons, this I didn't bring that up right away. In
Yes,
fact,
right.
it's not something that
That
we
you,
tend to reserve drilling in this day and age for persons for whom we have tried medical interventions and
that's what
it
I'm
hasn't
saying.
worked. In the past we used to be a lot more aggressive in terms of incorporating surgery, and ovarian drilling has been shown to be beneficial. But the reality of it is that if you can achieve something using a lower risk
Yeah,
procedure, why
right,
not?
right,
You know,
right.
so you not only do you have the risk related to the surgery, like scarring, as you mentioned, but you also have risk related to anesthesia, and
Hmm.
um, and so
Hmm. And, and
um,
and sometimes it doesn't work.
and sometimes it doesn't work, right?
Sometimes it doesn't work.
And you still need to.
You see why I brought that up is because as women are on here now, they're listening to you. They respect, your voice also, and we're just educating people. That's all we're
Mhm.
doing. We're just educating people, and I know a lot of them now is probably shocked because they didn't know that I knew so much myself. So it is good that we have had this talk, and I just want to say, Doc, it's been such a great honor and privilege of mine. And persons are still say they enjoyed, and people enjoyed it. Yes,
My
I see
pleasure.
Charlene enjoyed. I see Sister Denise Grant at church. Yes, really appreciate you educating us. As always, blessing to you, Dr. Campbell. Yes, somebody's asking, saying they have high thyroid. PCOS has anything to do with thyroid? Or
There
well,
can
let's
be
go this
there
way.
can be associations, eh? There can be associations. It's a separate disease, but
Yes.
a lot of the times you may find that in the process of investigating PCOS, we detect and discover thyroid disorders. So, for example, doc, if someone has low thyroid
Yeah,
function,
hypo, which would be
hypothyroid,
hypothyroidism.
then
Yeah.
they're also going to be predisposed to weight gain, and so therefore going to be predisposed to PCOS. So you can see how those things
Oh,
can
wait,
be
the
associated.
ripple effect. Ripple
That's right.
effect. Well, I want to say, I see Sister Yannick out there. I just want to say thanks to all of you. And it's been such a great honor and privilege. And now that you know what it's about, um, Doc, is there another topic that you have in mind that you would love to talk about? Pastor Black say
Well,
very informative.
I'm here to serve, as you know. But I don't understand. Young girl. You tell me that you wanted me to talk to you talk about menopause. That's what you told me from last year, that you wanted to talk
No,
about
we have to wait. We
menopause.
have to. See, we
I
have
said,
to. A lot of people is asking now for menopause. A lot of people is
okay,
putting up menopause. So we
all
had to
right.
wet. We had to wet them a little bit. So the
So,
next time
so
now, that be
next
sure.
quarter we talk
Yeah,
about
we can't
menopause.
wait till
All
no
right.
next quarter, Doc. All right. Well, I just want to say to all of you, thank you all very much. I see people still coming in, but we have to leave you now. We have gone overboard, and now you understand. The next time that you see that link come out for a webinar, you make sure you never miss it. Get notified, hit notified, and never miss it. Those of you on Facebook, big up yourself all the time, always there over the years. Those of you on YouTube, man, trust me, man, whether it's church or whatever, you're there. And I just want to say special thanks to all of you. I see coming out of Florida. Love it. And I just want to say thanks to all of you. God bless you, Lord. Have mercy on Inga. We see some of them from the West Bay Church. So many of them are on. Oh my Lord, at work, Doc. Somebody say this is very important program tonight. These are some of the topics that the church should be teaching, all the things in the church. Awesome. Awesome. So thank you for that. Minister Alish Bartley said, thank you much. Appreciate the information and looking forward to more like this. All right. So guess what? We have to go now. I know you would want us to stay all night, but Doc have to go and I have to go. So until next time, I just want to say I'm going to be taking you out with a beautiful little song here and just leave you to enjoy the music as we take you out. And so until next time, dig up yourself and rock yourself all the time. Stay healthy. Take your vitamins, get your irons, get in the sun, do a little exercise, as Dr. C said. All right? Don't just sit down there. Come on for the pile of cake. Yes, drop there. Sweetness, and let's take down that insulin business. All right? All right. See you. Ciao.